Good morning, everybody. Over the next 45 minutes, we will discuss how we engineer the future of imaging-based diagnostics. The companion piece, this is the companion piece to the article that you see on the right-hand side. These are my disclosures. So we should start by being very aware that the global cancer burden is increasing, and this includes prostate cancer, which you see down here, which makes up 13.5% of all the cancer cases in men. And if we focus down on prostate cancer and project over the next 20 years, what we see is a global increase in cases and in death rates from prostate cancer, projecting out to 2040. Now, it's important to remember that most deaths are caused by the late diagnosis of high-risk prostate cancer, and you can see that over here. So you can appreciate that high-risk and high-risk locally advanced cancers make up about a fifth of the cancers, but eventually contribute to about 2/3 of the mortality. So this is an important condition that we need to diagnose and treat. This comes in the face of a number of management challenges, and one of the management challenges is the earlier detection and treatment of the deadly forms of the disease on a background that we all know of a high rate of indolent cancers. Number two, there are heterogeneous outcomes, and these are related to uncertainties. These uncertainties are in the classification systems, the underlying genomics and molecular characteristics, as well as the variability in the therapeutic efficacy. Number three, we know there is a complex prostate cancer journey or pathway with multiple transitory states, and within these states there are changing clinical needs and priorities. So you can see the typical journey sketched out on this image, and you can see that mutational heterogeneity increases as you go from suspected cancer to death. You can see that men traveling this journey will have different priorities as they move from left to right, and the ability to cure patients is limited to the earlier parts of the cancer journey. So you can see this is quite a complex web that men will be traveling in their prostate cancer journey. Now, all the time, we've got this background of increasing data, increasing knowledge, increasing science, which is changing the precision of the care pathway. So we are moving away from the one-size-fits-all strategy towards giving more precise care. And more precise care is the right treatment for the right patient at the right time, all on a background of limited resources, both in high-income countries as well as low-income countries. So these care principles, which you see on the top right, the need to act in a timely fashion, means that we really need to think differently about men with prostate cancer. And one solution is, of course, imaging. And this is emphasized on this slide. We know that just scaling up imaging would prevent globally 2.5 million deaths, and in fact would have a benefit of $1.2 trillion. And if we combine imaging with treatments, what we notice is that we would save almost 10 million deaths with a huge net benefit of $2.7 trillion. So you can see how the impact of imaging alone could be in changing what's going on. Now, of course, we have all experienced this expanding toolkit of cancer imaging, but imaging by itself doesn't actually yield in better outcomes the imaging needs to be in an engineered framework of advancements. Well, what do I mean by that? Well, as we think about reimagining prostate cancer using these modern diagnostics, which include, of course, next-generation imaging, but also objective analyses and visualization, robotics, etc. But we have to manage this data through digitization, AI, the innovation cycle, within a framework of clinical trials that validate these imaging biomarkers and at the same time reduce biases. So we need to be able to be able to do this. What we need to do is to have a deeper understanding, an understanding of clinical needs in each of these states, and what contribution next generation imaging technologies could play in the precision of care. By that I mean that we need to develop really clear understanding of each use case in various parts of that journey. And I'll illustrate that to you in a minute. So we need to understand the clinical scenario and its pathological state, the problems with categorizations as we face it today, what the clinical needs are, and what the priorities are, what contributions imaging plays to the current standard of care, and what imaging could play to the future of care of these patients. So if we just take an example at the beginning of the journey and at the end of the journey, so let's say we're looking at men with suspected prostate cancer. Okay, so the use case here is a man with a normal or a raised PSA with or without a abnormal DRE, a man who is at suspicion of cancer because of a raised PSA but has had a negative biopsy, a man at higher risk, Afro-American history, family history, genetic mutations. So you can see how we're now defining the clinical scenario. But we also have to think about the problem of categorization that we face. So the problems of categorization, and these are outlined in the article on the bottom right-hand side, include the screening, the prevalence of disease. So in the screening setting, we know the prevalence is about 4%, but we also know that about half the men who die in a screening program of prostate cancer had a normal PSA at the outset, which is interesting, right? We know that in secondary care, so where the prevalence is of course much higher, between 30 to 50% in most series, that most men who are diagnosed will not die of their cancer. We said only about 20% of those men, the high-risk men, contribute to 60% of the mortality. We know that overdiagnosis and overtreatments are common and remain a significant problem, and we know that the confounding factors include a substantial proportion of men with a raised PSA who don't have a malignant diagnosis. So we're beginning to appreciate now what the clinical needs might be. So the needs might be to find out what the cause of a raised PSA is, and is it due to a significant tumor? How can you reduce the number of investigations, including MRI scans and unproductive biopsies? How do you reduce overdiagnosis of these indolent cancers, so reduce overtreatments? How do you localize where a tumor is in order to direct a biopsy? And how can we do this cost effectively and as quickly as possible, so reduce times of diagnosis? And of course, one solution that we are now aware of is, of course, prostate MRI. And this is a typical man. And you can see by the arrow that there is a carcinoma there, also shown by the AI. And this is then used to target a biopsy to that lesion. So in this scenario, as we stand today, what contribution can the next generation of solutions make to improve the precision of the MRI pathway? Well, there's a number of things you can think about. Number one, we can think about multivariate risk stratification tools. We can think about expanding the role of AI. We can think about robotic sampling of areas that we identify. We can think about normograms to improve the negative predictive value in equivocal MRI cases. We can talk about the ability of digital workflows to improve the efficiency of the MDT pathway. So you can see how, although we've introduced MRI, there's still work to be done. So these digital tools, these next generation tools, include a number of factors which you see over here. So let's put a bit of flesh on those ideas, looking at some digital tools for prostate cancer that are already available today. So for example, we have prostate cancer risk assessment tools, which will allow us to make decisions about the use of an MRI. We are already seeing the introduction of automation and AI to improve the consistency of image acquisitions and radiological reporting. We are beginning to see decision support tools to decide who needs a biopsy after an MRI. And we are now also seeing how digital workflows could help improve the efficiency of the MDT pathway given the number of patients that are coming through the clinic. So let's just take an example of a risk assessment tool. And this is a typical example of a risk assessment tool. It's a multivariate tool for calculating the likely prevalence of clinically significant cancer using commonly available clinical data. This is the tool that I prefer to use, and this is I tend to use this tool after an MRI. So if you have a 68-year-old man with a normal DRE, not Afro-American, with a family history, with a PSA of about 10, whose prostate volume is about 50 cc's, and it has a negative MRI, you can see that at the bottom here, the risk of clinically significant cancer on any biopsy is quite high, 37%. So this prompts me to recommend a biopsy despite the fact that the MRI is negative. So if we use tools like this, what we would find is that compared to biopsying everybody, if you took a threshold of 15% or greater as the likelihood of having clinically significant cancer, you can see that you would avoid about 1/3 of the biopsies, you would miss about 8% of the cancers that were there, but the number of unproductive biopsies would be halved. So you see how we've converted these ROC curves from that normogram into clinical utilities to get some sort of idea about how this might then translate into practice. Another tool would be something like AI, which is now again coming into the clinic. We have AI not only for automating the acquisition of MRI, but also in the analysis of the AI. So AI already exists in the pre-processing and the acquisition side, but of course AI comes into this image-based detection algorithms, but AI has a number of roles that it could play in the entire diagnostic pathway. And if we were to use AI, and these are some early data, what would you notice? Well, what you notice is that both for experienced and less experienced radiologists, the number of negative cases increases. So these negative cases actually increases with the use of AI, and the number of positive cases, in fact, decreases with AI. So you tend to call fewer suspicious lesions. But interestingly, currently you can see that it does not seem to reduce the number of indeterminate so-called PIRADS3 cases, although if you were to use an AI by itself, it calls very few patients as being indeterminate. So that speaks, I think, now to the issue of the lack of confidence by radiologists on what the AI is actually telling you. But you can see how the AI is already beginning to alter the diagnostic thinking of radiologists. The other interesting thing is, do these tools, these digital tools, AI detection, the ROI outlining that you see here, does that translate into the improved detection of clinically significant disease? And it turns out it seems to do that. So you can see the impact of AI in less experienced and in experienced radiologists. Now, obviously, the experienced radiologist has less of a benefit than an inexperienced radiologist. But the interesting thing is that an inexperienced radiologist with an AI is performing as well as an experienced radiologist without an AI. So you can see how you might accelerate the training and the reading of prostate AIs by using this next generation imaging technology, which is AI CAD detection. Of course, what that means is that there are some other stuff that we now need to think about. So, for example, what is the regulatory environment? How should we adapt the AI to undertake biopsies according to urological or patient tolerances to false positive results? And how will AI contribute to the current standard of multidisciplinary care? And this speaks to the need for a constant innovation cycle as we begin to introduce new technologies. So we will have to innovate around areas that we hadn't thought about before. So this innovation cycle then comes in, and we need to constantly be thinking about that. And one of the things that we need to think about is how we integrate AI with conventional parameters to improve diagnosis. How do we integrate AI into multidisciplinary working? In fact, data is already beginning to emerge around these areas. So, for example, this paper was published recently that showed that having a digital tool to support MDT working does in fact improve the efficiency and the quality of MDT meetings, but so far is not associated with changes in the oncological outcome. And that may be something that's worth having, regardless of improvements in oncological functional outcomes. The improved efficiency and the quality of MDTs is worth, it has real radiological value or diagnostic value. Now let's just apply these principles that we have learnt about to another scenario, and let's talk about metastatic castration-resistant prostate cancer. But one of the things I said that we needed to take into account as we think about dissecting these states is how do we incorporate new therapeutics, not just diagnostics, but new therapeutics. So, for example, let's talk about metastatic castration-resistant prostate cancer. And we first need to talk about new therapies that are beginning to be available for this state. And these include lutetium PSMA therapies, PARP inhibitors, and soon I think we will begin to see immunotherapies also coming into this state. So remember the first thing we said. We need to be able to understand the clinical and pathological state in this use case. So if you think about this use case, we have men with non-metastatic disease, we have men with oligometastatic disease, and we have men with polymetastatic disease. And we know that there's a variable rate of going to develop metastatic disease from M0 to M plus to M++. So we can identify already a number of issues with the current way that we categorize these patients. So, for example, we know that CT scans and bone scans perform poorly, particularly when we're trying to estimate the volume of disease in the bone. We know that CT scans and bone scans are particularly bad at showing therapy benefits from this next generation of imaging technologies. And we know clinically that patients can deteriorate without radiographically detected progression. So all of these things we know. So, for example, if you look at the triple assessment method of assessing response, which is by the use of clinical state imaging with bone scans and CT scans and looking at PSA changes, we know that clinical and imaging progression in the absence of PSA rises occurred in 55% of patients in this paper. We can see that if in the castration-resistant prostate cancer state being treated with abiraterone, for example, unequivocal clinical progression, which is the worsening of the clinical state not seen by a bone scan and CT scan, occurred in about 40% of these patients and had a worse prognosis. We know that enzalutamide, again in the castration-resistant state, you can have imaging progression without clinical or PSA progression in up to about 30% of patients. So you can see how we are now defining what the clinical problems are using conventional imaging. And then we have to start to think about how we might use next generation imaging technologies to promote not only this current standard of care, but the future of precision care. So, for example, we might want to find out who actually has oligometastatic disease so we can locally ablate those lesions in order to postpone the next generation of treatments, for example. We might want to have next generation imaging technologies to assess therapy response to limit exposure of potentially toxic treatments. We may want to use next generation imaging technologies to accurately identify anatomical regions where there are areas of tumor resistance so that we can go ahead and biopsy those areas. So you can just, now you can see how we might imagine these new areas of how we could use next generation imaging technologies to promote the next generation of treatments. So, for example, we could use whole body MRI to this. And so this is a whole body diffusion sequence before and after docetaxel chemotherapy, not in castration-resistant disease, but this time in hormone-sensitive disease, before and after docetaxel chemotherapy. And what you notice is that the retroperitoneal nodal disease has decreased in volume, and the bone disease, which you see here having very low ADC values, in fact develops very high ADC values. But the interesting thing here is, for example, the right ischium, the left femur, the left iliac bone posteriorly, the right side of the sacrum, still has areas of therapy resistance. Now, of course, what we can do is visualize this in 3D and try to aim needles at these areas to see if there are actionable mutations. And this was done in this paper. So you can see this man has castration-resistant prostate cancer. He has high signal on the high B value, low on an ADC, and he was biopsied in this area when a BRCA mutation was found. Now, of course, you can treat BRCA mutations with PARP inhibitors, and you can see that as he was treated with a PARP inhibitor, the ADC, in fact, increases. So this is before, and this is on the PARP inhibitor, the ADC increases. In other words, the patient is responding. But look what happens later on. He relapses posteriorly in the right iliac bone, so the opposite side, with a low ADC. And you see there, when this was biopsied, the BRCA mutation had reversed. So you can see how we're beginning to use imaging to target specific areas for actionable mutations that we act on, and then there'll be other areas that come along, and then we can see if there's anything we can do about it. Okay, and this in fact was looked at in this prospective study, which is still ongoing in Milan. You can see 30 men with metastatic castration-resistant prostate cancer were treated with cabazitaxel, and these men prospectively had CT scans, bone scans, MRI scans, clinic visits, blood tests including, of course, PSA. And what you'll notice is that this analysis was performed when there was progressive disease resulting in a treatment change, okay, which we call RAC5, Response Assessment Category 5, in 28 men out of these 30 men. Now, when you knew that the patient was progressing, so these 28 men, you can see that the MRI detected progressive disease in half the men. In the other half, the progression was detected by the MRI as well as the CT scan. And when we knew that the patient was progressing either on the MRI in all cases or in CT in half the cases, the bone scan was not reporting disease progression. And I just wanted to illustrate this here with this particular man. So you can see he's being treated with cabazitaxel. Here is the bone scan before and after. And it's actually quite difficult to say on the bone scans and on the CT scans that this man is progressing, but on the MRI, it's abundantly clear that he's progressing. And I just thought I'd show you a slice through the iliac bone. And this is, of course, at the baseline, and this is on the CT scan. And you can see it's very difficult to say that this man is definitely progressing on the CT scan, but it is very clear to see that this man is progressing on the whole body MRI scan. Now, of course, one of the things I said was that we have a new generation of treatment methods, and that includes, of course, lutetium PSMA in this state. So here's a man with castration-resistant prostate cancer, having had abiraterone previously, being treated with lutetium PSMA PET, and this is the lutetium PSMA PET before treatment, and this is after treatment. This is after 3 cycles of treatment, and here's the gallium PSMA before and after treatment. So you can see that he's in fact responded very well to this particular form of treatment. Now, we don't have to use whole body MRI. We can use, of course, PET scans. And in fact, the initial validation of a PET scan response assessment method, which is called RECIPT, has recently been introduced, which uses the concept of new lesions and a changing volume of lesions into a composite score that can distinguish between responders and non-responders and those people who are stable. So you can see how we're beginning to develop next generation imaging technologies to assess response of a next generation treatment. In this particular instance, of course, PSMA PET-CT. Okay, so as we think about these new solutions, we need to be careful about thinking of care impacts, biases, regulatory approvals, how we build clinical value, and how we integrate these new diagnostics with conventional and new biomarkers. So let's just spend a few minutes talking about survival biases. This is a very famous study comparing the use of bone scans and CT scans versus PSMA PET-CT in the setting of intermediate and high-risk prostate cancer and what impacts the new technology, PSMA PET-CT, would have on patient management. And what you'll notice is that there was an improvement in patient management in 28% of men, almost a third of men, using PSMA PET-CT compared to 15% of men using bone scans and CT scans. Okay, now, it's dangerous to assume that a management change will necessarily result in an improved outcome for men with castration-resistant prostate cancer. And this, I think, is very nicely illustrated here. So you'll see that this was a study that was recently published showing that in a randomized study, when men with asymptomatic prostate cancer had bone scans, and if they were asymptomatic and had a lot of bone disease, they underwent an MRI, which was the next generation imaging technology that they decided to use to see if there was cord compression. And interestingly, you'll see that about 30% of men who had an MRI had a spinal cord compression that was visible that required some sort of intervention. So this is radiotherapy, surgery, stabilization, whatever. Now, if you then follow these men over the next 5 years, and you can see this is the overall survival, this is over 2 years, this is over 2 years, you'll see that over that subsequent period, the men who had the intervention did no better on clinically relevant endpoints. So the clinical relevant endpoint, of course, when somebody has spinal metastatic disease, is spinal cord compression. And you see there is, in fact, no difference. Persistent neurological deficits, you'll see there were no differences. And over 5 years, in fact, there was no difference in the overall survival. Which means that just because we are able to intervene does not mean that we should intervene. In fact, what it means is that clinical trials need to be done to show the improvement. And that's where we get this disconnection between licensing and clinical use. So you'll see this press release that says that this new PSMA is approved for high-risk prostate cancer before initial curative therapy, and its use within clinical guidelines, which says that when using PSMA PET-CT or whole-body MRI to increase sensitivity, be aware of the lack of outcomes data on subsequent management changes. And it gives a very strong recommendation for that. Again, emphasizing that just because something is approved diagnostically does not mean it's going to be useful clinically until it is shown, of course, in prospective studies, and that's important to do. And this issue is raised by a number of papers that have been published over the last few years in prostate cancer. And I think the statement that best encapsulates this is the statement by Hussein, saying that the value of novel imaging comes when it is shown that these new technologies maximizes treatment benefits or minimizes undertreatments or reduces overtreatments, or while tempering costs and toxicities, okay, after biases are taken into consideration. So this is an important statement that we need to remember. And so what are these biases that we are talking about? Well, next generation imaging solutions, we know, improves detection sensitivity, lesion sensitivity. There's no doubt about it. It improves lesion characterization, improves specificity. But we also have to remember that by improving detection sensitivity, we're not only improving the detection of clinically important disease, we're also improving the detection of unimportant disease, perhaps indolent disease, more indolent forms of disease. And of course, we know that it improves bone response categorization. So these improvements, which are undoubtedly there, will lead to a number of biases, and that includes stage migration bias, lead time bias, and length time bias. So just to explain this in a little bit more detail. So let's say you use conventional imaging. You can divide men with metastatic and non-metastatic disease, and if you used a particular treatment, you can see that these would be the survivals for non-metastatic and metastatic, and of course metastatic patients are going to live less long than non-metastatic patients. And of course you can see these people here are not They're not all surviving. That's because there are false negatives in here also. Now, if you use a next generation imaging technology, this man which was not detected will move into the cancer category, but this man with the more indolent form of disease would also move into this category. Whereas the metastatic men here, there will be a false positive person here who then moves into this category. So you can see straight away that the prevalence of metastatic disease increases because you've now got not only these men, but the false negative as well as the indolent cancer. And these men will live longer because there is a dilution by indolent disease in this group. These men will also live longer because this false positive ends up on this side. So in fact, both metastatic and non-metastatic patients live longer even if you use the same therapy, right? So this is a spurious bias because the treatment didn't change. The individual patients were living just as long as they were all going to live. It's just the categorization to metastatic and non-metastatic changes. And that's stage migration bias and the Will Rogers effect. The other thing you have to remember is that by the earlier detection of a disease that's going to kill a patient, the apparent longer time of survival is just a lead time bias. And the over-detection and the over-treatment of a man with an indolent form of disease causes length time bias. So all of these biases are all acting all at the same time, and we need to remember that this is happening with next generation imaging technology use. So as we think about building real clinical value, we need to move beyond what we normally do, which is go up to the point of diagnostic thinking. If we want to build real value, we need to go and think about the therapy impacts with all the caveats that we've already discussed, but also to start to look at patient outcomes. So what we need is a framework for the development of an imaging biomarker. So let's say you've developed this new technology. What should we be thinking about? Well, the first thing is to define use cases where changes in management plan would be possible from the use of the imaging test, which is what we've just been talking about. So in other words, what is the use case? We have to make sure that the biomarker that we're developing is independent of and adds to a traditional risk factor. And we have to ensure that the improved use of this new biomarker improves the discrimination of patients for meaningful clinical endpoints. Now, just let's dig into those first three principles. So in other words, let's talk about enhancing discrimination compared to a traditional biomarker. So if you look at this data, what you notice from the ROC plots is that if you use PSA alone to detect clinically significant cancer, that would be the ROC curve. If you use the MRI alone, that would be the ROC curve. But if you used MRI and the PSA density, then that would be the improved discrimination. So what you notice is that the specificity improves with the use of MRI scores and PSA density. Now, how do you convert these ROC curves, these accuracy, sensitivity, specificity, into what are called clinical utilities? Well, the first thing we need to show is that the PIRAD score and the PSA are independent of each other. And of course they are, right? They are. So in fact, what you can do is you can take let's say this table from the EAU guideline and separate out the data. And you'll see on the top left that the higher the PIRAD score, the greater is the prevalence of clinically significant cancers, and the higher the PSA density is, the greater is the likelihood of clinically significant cancers. Okay, so you can see that these are in fact independent, and if you combine them, this is how they would be. So that's PIRADS 2 and 3 with different PSA densities. That's PIRADS 3 with different PSA densities, and this is 4 and 5 with different PSA densities. So if we then start to think about the clinical utilities that we're interested in, the clinical utilities we're interested in is how many biopsies are avoided, how many clinically significant cancers were detected, and how many false positives were there. In other words, biopsies without clinically significant cancers that were found. So these are relevant clinical utilities. So if you were to do just the PIRADS way of doing it, if you were just going to biopsy everybody, then of course you would biopsy, nobody would avoid a biopsy. You would detect all the cancers, but 63% of the biopsies that were done would be false positive. In other words, biopsies that did not yield a clinically significant cancer. Now, if you were to just use the MRI method, you'll see that what happens is you avoid about 40% of the biopsies, which is here. You miss about 6% of the cancers, but you halve the number of biopsies without clinically significant cancers goes down to 45% from 63%. So that's a real improvement. Now, if you were then going to combine the MRI approach with the PSA density approach, what you notice is more men avoid a biopsy, so an improved clinical utility. You'll miss 2% more of clinically significant cancers, but the number of false positives also decreases from 45% to 39%. So this is how you translate an ROC curve into a clinical utility that you can then begin to appreciate what the impacts of this might be. And this is how you develop a biomarker. But in fact, you can go further from ROC curves to decision curve analysis. I'm not going to go into that in any more detail, but that's how you go from ROC curves to clinical utilities, and then from these clinical utilities you can then go ultimately to decision curve analysis. And decision curve analysis also takes into account patient and neurological preferences. So that's what I meant by how to develop a biomarker step by step by step. Okay, so I'm going to stop there with these final take-home points. As we think about designing solutions to generate a clinical benefit, we need a deeper understanding of the clinical needs. So in other words, we need to recognize these use cases, as I illustrated for a couple of states. We need to focus on developing imaging biomarkers that integrates into the pathways, either by improving diagnosis, improving prognostication, or predicting who would get a benefit. Remember that imaging is not the solution. Imaging is part of the solution. In other words, that integration to improve discrimination is important, and we need to show these net benefits through those clinical utilities as I just demonstrated. Remember that radiological value is not the same as clinical value. Radiological value includes increased time efficiency, for example, or improved working. That isn't necessarily clinical value. And the other thing to remember is just because you've got a regulatory approval of a particular diagnostic does not mean that that approval will result in an improvement in clinical value. That has to be shown by a different series of experiments. In other words, we all have to engage in studies that look at clinical efficacy of these next generation imaging technologies, because the basic tenet is true that if you want to go fast, you go alone, but if you want to go far, you need to go together. I hope you found some of these comments useful as you think about developing your own biomarkers using next generation imaging technologies. Thank you very much for listening. Bye-bye.